Are you able to see my screen okay?
Yeah.
Great. So I wanted to offer some tips and tricks and just a perspective on outpatient total joint replacement, or, as it may be called, daycare joint replacement. Very briefly, I wanted to mention just the evolution of outpatient joint replacement in my hospital. We didn't start with this. Very similar to what many of you've seen. In the 80s and 90s, this was a completely different operation. People would be admitted preoperatively, would be in the hospital for an extended period of time, and be out of work and out of commission for a great amount of time. In the 2000s, there was a push towards rapid recovery. At my own institution, when I arrived about 10 years ago, a 3-night stay was considered standard. And we decided, hey, we want to really try to get people out the next day, a post-op 1 discharge. And over the course of 3 or 4 years, we were able to successfully achieve that to the point where, 4 or 5 years into it, a third to a half of our patients were going home the next day. In 2017, we started planning for our outpatient program, and in 2018, we implemented it. And I put that there intentionally, meaning probably one of the most important parts of setting up a successful program is making sure that all the stakeholders are involved. And it does take time. This is not something that you as the surgeon can achieve on your own. There are multiple tips to making this work well, but certainly engaging the entire team is an important part of it. And that's why it took us a year to put it together, even though it was my main focus and drive. I do these out of the hospital, and in the United States, many of these are done out of an outpatient surgery center. And the reason I put this here is I think that this concept will be coming sort of across the world in India, where people are starting to do these in an outpatient surgery center. I think doing it in the hospital to start allows you a little bit of a safety net, and frankly, it can be done there, even though the mentality of the hospital traditionally is to stay for at least overnight. These can be done in a hospital setting. But before we get to the tips and tricks as to how to do this successfully, we should really ask ourselves why. What is the benefit of doing this on an outpatient basis? And it turns out there's numerous benefits for both the providers as well as the patients. With the way we do surgery now, we know that a 3 or 4 or 5 night stay is not necessary. Not only that, we know that there are some detriments to staying to the hospital longer. Part of it is comfort, and this is really a psychological and cultural phenomenon where we have started to see a shift in patients from feeling safer and more comfortable in the hospital to realizing that they're actually happier at home if it's safe for them to be there. If you can take away their anxiety of leaving the hospital, they're actually happier sleeping in their own bed, eating their own food, using their own bathroom, watching their own television. Just like when you go on vacation and you're at a hotel, it's comfortable, but it's a little bit different than when you're on your own at home. And secondarily, a decreased risk of hospital-acquired illness. Obviously, with COVID, this has become even more relevant and germane, but there's clearly good reasons for us to pursue this. And in general, outpatient total joints is here and growing. When we look at orthopedics, when certain trends start to take off, we know that they're going to be present, as time goes forward. And I think that in the United States, and I'll show you a graph later, the burden of joint replacement continues to increase, and the proportion or percentage of those that are going to be done on an outpatient basis is certainly growing over the next decade. And then finally, it's safe and good for patient care. All of these things don't matter if this is unsafe or not something that is the best for our patients. And it turns out that it is. And then finally, as time moves forward, efficiency and value are very, very important. In the United States, we're convened under a bundle, or some hospitals are for government insured patients, where in the reality of economics and medicine, things are going to have to be done with better value. So higher quality, lower cost, and being able to get patients home the same day or very soon after that is going to be important to engaging payers in order to be able to make this, frankly, financially viable for both the patient, the payer, and the institution. Again, the most important thing is to put the patient first. None of this matters if this isn't safe or if it isn't good for patients. And it turns out it is. This is just one article from the Journal of Arthroplasty, but if you've been following the literature over the past few years, you know that when this is done correctly, it can be done very safely. And we're going to talk about some of the things that make it more safe. At the end of the day, when we talk about tricks and tips of how to succeed, what we're really talking about is how do we avoid complications. Everybody here knows how to do a simple primary hip or knee replacement, but how do we transition that to an outpatient space but avoid new complications or new poor outcomes that we don't usually see in our inpatient population. So as Dr. Khan said for his uni talk a second ago, and this is probably a common theme that you hear, patient selection is by far the most important. This is not something that can be applied to all patients. And the patient selection goes beyond objective medical data. And we'll talk about this in more detail, but there's a certain type of patient that does better with outpatient surgery and a certain patient that doesn't. In fact, it's so important that it's my number 2 tip as well. So number 1 and number 2 are patient selection. Number 3 is a team approach. As I alluded to earlier, this is not something that you can do in a vacuum. You will need to engage your entire team in order for this to be successful. Number 4 is surgeon confidence, and I'll go into a little bit of what this means later on in my slides, but essentially you don't want your first case out of training to be an outpatient total joint. You need to have everything set where you know you can reliably perform an efficient and safe operation reliably every single time. Enabling technology, I think that this is critically important now and will continue to be more important as time goes by. We now have technological enablers that allow us to do these procedures more efficiently, more safely, and more accurately. And I think that all of those things lend themselves to safer outpatient joint replacement. And then finally, just to stick it in again, patient selection is by far the most important part of all of this. And I know I sort of jokingly put that up there 3 times, but it's really important. If you think about the actual surgery that we do, and the actual patients we're operating on, nothing has changed from 5 years ago to today. Maybe small changes when it comes to enabling technology, but the operation is not dramatically different. So why are these people being able to go home? And again, there's a lot of these things that go into it, but picking the right patient and understanding who can do this is critical to success. So to start a little bit on patient selection, the most important thing is that you need a motivated patient with appropriate support. What I've learned is trying to fit a square peg into a round hole with this does not work very well. There are some patients that are very apprehensive about going home the same day. If you try to convince somebody that is absolutely fixed against going home to try to go home that same day, it's not going to work very well. And remember, this is an evolutionary or iterative process where as time goes by and outpatient joint replacement becomes more common, when they hear it, when they don't say, oh my God, I'm going home the same day, this will change. But you need to find a motivated patient, somebody that wants to go home. They also need appropriate support. Somebody that lives by themselves is not going to do very well, even if you have appropriate home health and supportive therapies. You need somebody that has a good team. Patients that come in for outpatient total joint replacements, I require them to come with I call them their coach, whether it be their spouse, their partner, whoever's going to be responsible for them after surgery. I ask that person to come to the pre-op visit so I can explain what's going to happen and what's going to go on. This helps to decrease the anxiety for the patient as well as improve the medical outcome. And you have somebody to talk to if they think something is going wrong, if they need to be seen sooner rather than later, you have a point person. So as I said, reliable coach. Medically optimal, this is obvious. You don't want to be taking care of your sickest patients on an outpatient basis. Above all, we put the patient first and we want this to be safe. So medical comorbidities are things to be avoided. And then age, and this is relative. When I started our program, all of our outpatients were less than 60, then they were less than 65. And a month ago, I did a 79-year-old as an outpatient total hip, and he did great. So part of it is finding where you're happy and comfortable. And again, picking the right patient. These are some general guidelines, and this is common sense. Avoid the sicker patients when you're starting to do this. Urinary retention is an interesting one in that all of our patients, which I'll show you later, all of the patients that we've identified of outpatients have gone home. The closest we came to having to admit somebody was a 70-year-old male who just couldn't urinate after surgery, and he had a history of BPH, and we gave him some Flomax and he was able to go, but he ended up staying till about 5 p.m. before he could go home that day. So look out for that, especially in your older male patients. Some simple ways to start screening, and these aren't hard and fast rules, but for just simple ways for you to think about it. When you start out, obviously you want simple cases. You don't want to have to do those difficult revisions that Dr. Rajgopal just showed us, obviously, or anything very complex. You want to start with your easiest cases, young, strong patients that are not heavy, so BMI less than 35. As you move along and become more comfortable, it's okay to stretch these indications. As I said, age is not an absolute indication here, but something that in combination with patient selection and their medical comorbidities can help to guide you initially. These are really critical for success, and that's why I put them up here again. Selecting the right patient is very important. And as you start your program, you will see those that fit this better than others. The next is a team approach. This is not something, as I said, that you can do just as the surgeon. You need to coordinate with all the relevant stakeholders. Anesthesia is critical. we really need to work with our anesthesia colleagues in order to be able to provide anesthesia that is quick in its ability to wear off, right? We don't want somebody to have a block that lasts 8 hours if we want them up and walking 2 hours after surgery. We want the patient to be hydrated appropriately so they don't feel nauseous after surgery. So these are all things that we need to work together closely with our anesthesia colleagues. What I would recommend is that you find somebody that's very interested within your anesthesia department in developing this protocol and work closely with them to figure out the best way to do it. And we can talk about that in more detail. I'll try to keep this short, but ultimately there's a lot of data out there as to how this can be done safely. And we'll talk a little bit about the anesthetic approach that I use, but ultimately turns out it doesn't really matter whether you do a general or a regional. There's a way to do it successfully with both. It's more about limiting the narcotic use and limiting nausea and vomiting after surgery, which is almost always directly related to hydration. Nursing is important. And again, part of this goes into the psychology of this. If your nurses are going to see the patient and are not in the mental space that this patient is going home the same day, it's not going to go well. Everybody has to be on the same page and have the confidence that it's going to go well. PT, or physical therapy, or physiotherapy, as you may call it, is also a critical stakeholder. These are we again all work together to say this person can get up safely, can walk and get out of the hospital later this afternoon. And by all being on the same page and sharing with them that this can be done safely, it can be a really successful approach. Home health is an interesting topic. In the United States, when we first started doing these, every patient got home health. There would be a nurse and a therapist that would go to their house on a regular basis. That's not always an option here in the United States, depending on the patient's insurance coverage. And in places, in India and in other places, this may or may not be a reliable option. But if you have the ability to use home health, especially when you're starting out, it's a nice safety net. It allows a medically trained pair of eyes and ears to go see the patient and share with you. Interestingly, I think technology is helping us to limit this. We now have iPhones and FaceTime, and frankly, much of the orthopedic assessment can be done that way. Unlike cardiologists who may need to listen to the heart very carefully with their, most up-to-date stethoscope, for us, really, it's looking at the incision and seeing how the patient's doing. And technology like FaceTime can really help us enable that. And then administration is very important. Your institution has to be behind this program, because in order to get all of these other services in line, there has to be an idea or a concept that we are going to do this together. So the hospital administration, the business people in your hospital need to understand why this is important and good for patient care, and then work with you to bring the relevant stakeholders together. As I said, this team approach can be a 40-minute talk on its own. We have a couple of ViewMedis that do a nice job covering this in detail, including going over the anesthesia protocols, and I'd encourage you to take a look at those if you're interested. Surgeon confidence, as I said, this is not you don't want to do your first case as an outpatient. You need to be comfortable that you can do a reproducible approach every single time. You need an experienced team. So again, it's not just about you, but you need to be in a place or in a system where you have a reliable team that can reproduce the intraoperative experience every single time. This is not a case where you want to have a range to say, well, this case might take between an hour and a half and 2.5 hours. That's not okay. You need to be able to do these in a reproducible manner where you're going to be around an hour in terms of your surgery. Obviously, pick straightforward cases, especially as you're starting. You need reliable implants, okay? So pick things that are tried and true that you're very comfortable using. Your first outpatient joint isn't the time to try a brand new implant for the first time. And efficiency. We try to target an hour or less. We've been successful with that. I think this really helps the anesthesiologist in terms of them having confidence that they don't need to over-medicate the patient. If you demonstrate in your prior 500 cases that you can be done in 45 minutes every time, they will give the patient the short-acting spinal in order that will wear off in an hour and a half. Whereas if you can't do that, they might give them an 8-hour spinal because they're not sure you're going to be done in time. So you need to be able to demonstrate efficiency. I think enabling technologies are really helping to push this. And just to be clear, before we get to this slide, I don't think enabling technologies make up for any of the other things that I've talked about. They all need to be there. Enabling technologies aren't going to help you skip any of those steps, but they will help you, once you've established those steps, do this even more successfully. Patient-specific instrumentation has been really critical for me. Robotics can also provide some of the same feedback and data for me. For the knees, I use patient-specific instrumentation. Negative pressure therapy for the incisions. I was very concerned about sending patients home and what kind of dressing to use with them. Negative pressure for my outpatients has been a really successful endeavor for me. Using liposomal bupivacaine has been very successful for me. Interestingly, I don't think that this makes or breaks the whole deal. I use it on my outpatients. I think it's beneficial and helpful, but it's not a party trick, meaning I'm not numbing them up so much that when they go home in 24 to 36 hours, this wears off and they're screaming in pain. So it's a useful adjunct, but it doesn't make up for being minimally invasive and not traumatic to the tissues as you go through this. As I mentioned before, one of my big early concerns was incision management. I wanted something occlusive and antimicrobial and compressive without the need for multiple dressing changes. So for me, I've used negative pressure for my outpatients. I use it on all of my outpatients, and really, we don't really get many phone calls at all about wound or dressing issues, which is a huge relief. Now, of course, these are the skinniest, healthiest, most cherry-picked patients. So yeah, we're not doing this on obese hips that are going to drain. Nonetheless, having the incision to not to have to worry about the incision has been really important for me. Patient-specific instrumentation, as I said, has been very helpful for me. It helps me with improved OR efficiency. Not having to cannulate the femur on total knees, I think, adds into decreased pain post-operatively. It also reduces the number of trays you need in surgery, which again, all goes to this efficient outpatient mentality as opposed to the traditional inpatient big surgery thought process. I think it's important to use the right kind of implant, especially on the knee side, as implants continue to evolve. I think that having a more congruent and kinematically matched implant helps. Dr. Khan actually referred to this in his last talk when he spoke about the screw home on the medial side of the knee. As we know, for example, with ACL tears, even though an ACL tear is not a knee replacement, but it takes a great deal of time for them to regain their proprioception. Why is that? The knee doesn't feel natural immediately afterwards. So when you're talking about a knee replacement, when they take that first or second step, the more natural that knee feels as they're taking that first and second step, the more quickly they'll be able to recover. That's what I'm saying. Proprioception is really critical for early success. On the day of surgery, what do? We do a minimally invasive approach. Now, interestingly, with the hips, I think not cutting the abductors is important, but I don't think this is limited to anterior only. I've done anterior lateral, direct anterior, minimally invasive posterior lateral, and frankly, now I do all of these mini posterior lateral / direct superior. For me, it was the most reliable way of getting it done, and we literally have people that are leaving the hospital 5 hours later. So we had a talk earlier on dislocation that talked a little bit about potentially the advantages of anterior being diminished or being shown to be diminished as time goes by from that front. I don't think that this is an anterior only operation, and sometimes that gets mixed in with this. Certainly an anterior, if you're comfortable with it, is a fine way to do it, but I don't think that you have to say I can only do an outpatient total hip if I do an anterior hip. With the total knees, again, I use pre-op custom guides. We preserve the quad, minimal soft tissue trauma, so you'll learn your best way of doing that. And again, a very quick case. In terms of the anesthetic, it needs to be light. It can be a spinal or it can be a general, but we need to really limit narcotics. The PACU team or the post-anesthesia team is very versed in getting these people up, moving, eating, and drinking very quickly. Immediate physical therapy, and we try to have these people home by noon. So we usually make incision on the first one around 8 and on the second one around 8:45. And usually for the outpatients, those are the first 2 cases of the day. But we try to get them home within basically 3 to 4 hours of their incision. And it can be done successfully. A lot of this is mental. As long as everybody's on that same page, it works. And we're not rushing the patients out. It's just that everybody has this idea of this is a young, healthy, good to go patient. We're going to move them through this process. I do think they require close follow-up. So these are patients, I give almost all of them my cell phone number and I say, call me if there's any problems. I call every single one the night of surgery and the next day. It's funny because I used to call them the second and third day, and then they'd be like, kind of like, why are you bothering me? I'm doing fine. Should I be worried about something? So now I just do the night of and the next day, but they do warrant close follow-up and maybe having your nurse check in on them a little bit more regularly. Our results so far. So again, I do about 500 cases a year, but this has only made up 200 of my cases over the past 2 or 3 years, in that you got to pick the right patients. I'm not trying to apply this to everybody, but we've had 100% success rate, meaning every single person that I've identified as an outpatient has gone home that same day. I mentioned that urinary retention patient that almost didn't make it, but we're 100%. And that's not because we're doing anything magical. It's because we're picking the right people and applying the correct protocol. We've had a 0% readmission rate, knock on wood, with these. Again, we're picking the healthiest, best patients and giving them the closest follow-up. But in the right patients, it can work really well. These patients aren't coming back the next day screaming in pain and having to be readmitted. That's not what's happening. About half of our patients that have this do not use any opioids, which is another sort of emerging area of opioid-free surgery. The other half are off by the end of the week. patients really appreciate this approach. The right patient loves being able to go home the same day. And a lot, again, this is cultural and sort of the societal mindset on this. All of our employed patients have been back to work within 2 weeks. Granted, those are desk jobs, not heavy labor. I alluded to this earlier. Whether you like it or not, outpatient total joints are coming. This is a look at the US market. And they estimate that by 2025, 45% of total joints will be done on an outpatient basis. And I think if it wasn't for COVID and sort of having this one slowdown, this would be even higher. And so once that happens, I think by 2025, 26, that will be the case. COVID-19 obviously has made this even more relevant. We really need to still be taking care of our total joint patients. Obviously, elective surgeries have become pushed to the back burner a little bit, but when we have debilitating DJD is a significant medical condition, and we need to find ways to care and treat for our patients. And I think that outpatient total joints is a unique way of moving forward within the COVID era, and whatever the next pandemic is going to be. So in summary, teamwork and planning can facilitate an outpatient total joint, and it needs to be done in order for this to be done successfully. It's not just a surgeon operating in a vacuum. Anesthesia and pain management are critical.